Welcome to the Finding Financial Freedom podcast with the Frugal Physician, where Dr. Disha Spath will be your companion on this exciting financial adventure. Get ready to conquer debt, build wealth, and embrace a mindful spending lifestyle that will empower you to live life on your own terms.
Welcome back to the Finding Financial Freedom podcast. I'm your host, Dr. Disha Spath, aka the Frugal Physician. Here we explore how physicians can build wealth, reclaim joy, and live life on their own terms. Today's guest brings a powerful blend of surgical experience, legal insight, and mentorship. Dr. Stephen Cohen is a board-certified colorectal surgeon with over 30 years of clinical experience, a medical legal consultant, and a passionate educator. We're diving into a conversation that touches on burnout, resilience, financial literacy, and the wisdom that comes from lived experience. We're going to talk about getting sued. It's going to be uncomfortable. Dr. Cohen is going to tell you how you can get better at navigating this if you have to, because all of us doctors need some coaching when we get on the stand. And it's important to remember that this is just part of the job. Not all lawsuits mean that you did something wrong. Dr. Cohen is going to be here. He's going to teach us about it. So let's listen and learn and get going. Dr. Cohen, thank you so much for coming.
Thank you for the opportunity. I'm excited to give some insight into my world.
I'm so glad you came today. You know, this is such an important topic, not a topic that a lot of doctors like to talk about, but it's something we need to talk about. We need to be prepared. But let's start with you first. Let's start at the beginning. What inspired you to become a colorectal surgeon, and how has your career evolved over the decades?
Yeah, that's a great question. So, my father is a retired general surgeon. My mother was a school teacher. I have three brothers. I have an older brother. I have two younger brothers. All of us became surgeons. So,
Wow.
I think, my father was a great mentor. I watched my first appendectomy at age 11.
Wow.
I did get a little nauseous. I didn't tell him that because, I wanted to put on a good show. But, I've always been around medicine, always been around hospitals. I knew I was going to be a surgeon even in high school. I was in a 7-year BS MD program at UCLA, surgery training at Boston University, then a colorectal fellowship at the Cleveland Clinic. I didn't know there was actually a colorectal field when I first started. I figured I was going to be a general surgeon. I had some great mentors in one of my hospitals that I rotated in Boston at Leahy Clinic, which is a premier colorectal, program. And I like the fact of those disease processes. I like the fact that most general surgeons are scared of the anus, believe it or not. I know it sounds silly, but the hemorrhoids, the fissures, the fistulas, you get immediate gratification of fixing somebody's bottom. And, what I realized over time, it's a very litigious area. If you don't know what you're doing and you do something wrong, you make the patient incontinent. That's a problem, right? So I wanted to be a specialist. I had great mentors. Most colorectal surgeons don't get up at 3:00 in the morning. That I like that part of it. You high volume, busy surgeon in the daytime, and you get a wide array of clientele because I can drain an abscess, a perirectal abscess in a 9-year-old, and I can operate on a 105-year-old with a rectal prolapse. So men and women, all age groups, becoming a specialist was important so I can learn a lot about one particular field.
Well, it sounds like your dad was an excellent role model if all your siblings and yourself went into surgery. And I agree. I mean, colorectal surgery is so important. It's one of those things that people don't really like to talk about, but everyone has an anus and a rectum, so anyone can need it. And I agree. It's a really fascinating field. And though I couldn't do it, I'm really glad you do. Before this episode, you said to me that real wisdom comes from scars and stories. So can you share a moment that profoundly shaped how you practice medicine and show up in medicine?
Yeah, there has been a lot of things along my career that have really shaped how I teach, how I train, how I educate. and how I take care of patients. I mean, and I tell the residents this all the time. It is very easy to be a doctor when everything is going according to plan, when you have an agreeable patient, when you have an agreeable family, when there's no complications. But that's not the norm, as you know. We have patients that don't want the suggested surgery or medical therapy that we offer them based on our education, experience, and training. There are complications that you are going to get as a surgeon, whether it's a minor urinary tract infection, whether it's a major pulmonary embolus that the patient dies, or they die of a heart attack, that there was no indication pre-op that you needed to do anything. My very first experience of this was as a resident. It was my first day in the intensive care unit at Boston City Hospital. And the chief resident said, "Who is the new intern?" And I meekly raised my hand because I'm scared about everything in the 80s, because I thought I was going to get fired every day I went to work. And I knew I didn't know anything. And why are they asking me? Because I knew I didn't know anything. Yeah, it's amazing as a resident. On Friday, you're a medical student. On Monday, they hand you the beeper and you're in charge. Right. And I say, seriously, I didn't learn a lot over the weekend, but okay. So that first day in the ICU, they point me out as the new intern. The chief resident says, "Go into the waiting room." We were rounding on an 18-year-old who was just declared brain dead, and I was to tell the family that we're pulling the plug. Okay. And I'm thinking to myself, you wanted to be a doctor, put on your big boy pants, because it's not all roses, right? And I go into the waiting room and there's 30 people there. They're already crying. And you just have to, muster up the strength to be compassionate, to be empathetic. I didn't know the patient. I don't know the story. There's 30 people wailing and crying. And of course, they directed their anger, their frustration at me appropriately because I'm the face of giving them bad news. But over my career, there's been many things like that where patients die of things that we didn't anticipate, the heart attack, the pulmonary embolus. So, those learning experiences, and I tell the residents the thing that separates the good doctors from the mediocre ones are the ones that can look at it from a patient standpoint. We see them at their worst, right? And it also drives me crazy when we don't humanize them, right? And I tell the nurses, don't tell me to go see the gallbladder in room 3. That is a patient with a name, with a family. And when you're on the patient side, you see that, but you don't see that all the time as a doctor. So it's important to treat patients like they're your family members. How do you want your mother treated? Right. So when you look at it from that angle, I think you become a more compassionate, empathetic doctor. And you just have to learn to navigate those difficult situations because they're going to come up.
Well, I 100% agree with you. It's almost like in training, we almost get trained to dehumanize the patient a little bit, right? Like create a little bit of space that we can handle our own emotions. But I think growing as a doctor is reintroducing that connection and being empathetically able to experience the patient's experience, right? And treat them, like family. And I think that takes some time and effort. I mean, thumbs up to you. It looks like you got thrown in the deep end as an intern.
Put on your big boy pants. That's what I said to myself. You wanted to be a doctor. It's not all easy. That's right. But you only learn that with the experiences, because how would you ever, you don't get that experience without going through it. Right. And you have to, it was good that they gave me some autonomy, as uncomfortable as it was. I mean, this was in 1987. I mean, I was born, I'm 25 years old. Right. So I was young. I felt, I was a doctor. I felt I was old, but I wasn't old. I was 25 with very little experiences like that. So I like to give my own residents some autonomy to do things like that. And they should be a little bit uncomfortable because I can't be with them the whole time. Eventually, they're going to graduate. They're going to be in charge. They have to know how to handle it.
How did you process your own emotions after dealing with that and sharing with that family?
I mean, just cried with them.
Mhm.
You have to show your emotions. I mean, it's hard. It's hard to not have your emotions with that.
Yeah.
So it's sad. Yeah, it's
Yeah.
just sad. And it's okay to do that. It's okay to share your emotions with the family. I mean, I don't think they expect any less. I think most families appreciate that.
Right. Right. Well, I'm sure I would appreciate that as a patient if you shared with your emotions with me if I was going through something really difficult. Well, let's shift gears a little bit. You've bridged two worlds, surgery and legal consulting. That's the other thing you do. What pulled you into the medical legal field?
That's a great question. That really happened by accident. So my first year in practice, I was asked by my senior partner, he was busy. Do you have time to review a case? And I said, what does that mean? He says, an attorney's going to ask you to look at a case and you opine, did the doctor meet the standard of care or not? And I thought
Hmm.
that was interesting. So over the years, having spoken with different lawyers, they like the way that I explain the medicine to them. I was involved in both plaintiff and defense. It didn't really matter to me what side was asking me, and sometimes I'd even forget. But I enjoy looking at a case, going forward to try to figure out what happened or what should have been done. And I've always been involved, even in private practice. I spent 23 years in the private sector. Currently, I'm at the VA Medical Center. I'm a federal employee, but I've always been involved in the teaching, training, and educating. And the way that I look at medical legal work is I'm doing the same thing. It's who am I teaching? Well, I'm teaching the attorney. They don't know medicine. They didn't go to medical school. They can look it up online, but it's real world experience, it's guidelines, it's standard of care. It's what a reasonable, prudent physician would do under similar circumstances to a similar patient. Patients all present with different comorbidities, right? But it's no different in the medical legal space that I'm doing what I'm teaching the residents. It's who I'm teaching. And I will tell you, it is very difficult to explain complex medical issues that we fight amongst ourselves about to a jury, which maybe has an eighth grade education, and it's not their fault, right? But the only way the system works is that if you have board certified, well qualified physicians actively practicing to be able to walk into a courtroom and explain it to the jury. I do get pushback from my colleagues at how dare you talk to plaintiff attorneys. And I said, what are you talking about? Do you and they say, well, that's not fair to the other doctor. I said, well, let me give you a statistic. And this is true. It's been true for the last 30 plus years. About 40% of the time, when I get asked to review a case from a plaintiff attorney to opine on standard of care, 40%. I tell the attorney there is no breach in the standard of care. This doctor did everything correctly. He was caring, he was compassionate, he dictated the operative note correctly, he followed the patient. The patient had a bad outcome. So I have saved hundreds, if not thousands, of lawsuits that may have gone forward if they didn't have an honest person to testify. So why do I say an honest person? I've been sued myself. And I will tell you, and I definitely hate to say this, but I've said it before, the truth doesn't matter when it comes to these types of things. You can pay anybody lots of money to opine against another doctor, and it's happened to me, where the expert that they hired to testify against me bald-faced lies under oath. But who calls them on that? There's no repercussion. There's nothing that can happen to a practitioner's license, board certification, if they're not honest and testify honestly under oath. That also drives me crazy, obviously. So, most of us that get into this work take an oath to abide by testifying honestly.
That is really surprising to hear. And I'm sorry you experienced that. When people think about getting sued, it's obviously incredibly stressful and My sympathetic response is literally kicking in right now. I'm sweating, right? Even as we talk about it. There are a lot of emotions that physicians have when they get sued. Tell me about how to deal with that. How do you deal with that?
Yeah, well, you go through the 5 stages of grief. I mean, it's no different when you lose a loved one. I mean, you really go through the anger, the frustration. You go through all that because you're immediately told you can't talk to anybody. Okay. You're immediately put on the defensive and you're immediately emotionally drained because you feel like you're a bad doctor. I felt like I was the worst doctor ever.
Right. How do you go to work the next day?
Well, it's tough. It's put on your big boy pants and I think men are different than women. I tell my wife this all the time. I can put it in a box and put it away and take it out later. My wife cannot do that. Everything is all jumbled around in her mind. And so I think for men it's easier just because we're wired different, but it does take a toll. And these things don't go quickly, right? I mean, some of these suits will drag on for years. They make this motion, they make that motion. You have to get a deposition. They hire expert. It takes forever. And every day you wake up and it's hanging over your head and it's very frustrating. And really medicine and law are two different things, right? The attorneys go to school to pose the question to get the answer they want. And I've had enough depositions. I know their tricks. If you've never been it through before, you will not know their tricks. But there's books written for them to do this. I mean, just like there's books for us how to take care of things. It's amazing. And I'll tell you a quick story is I was defending another colorectal surgeon that did everything right, bad outcome, got sued. And in his deposition, the very last question he was asked, which was the nail in the coffin, it was the thing the jury found at the time of trial that went against him because he didn't know, never been sued before. The very last question that plaintiff attorney asked him was, "Doctor, knowing what you know now that happened to your patient, are you going to change your process and do something different?" And he answered, "Yes. Thank you, doctor. No further questions." He went to the jury, right? Again, why do I say outcome is irrelevant in standard of care? Did that doctor know the outcome before he met the standard of care? No. A better answer would be no, because I met the standard of care in the patient I was taking care of. There's no need to change. This was a bad outcome. That's not predictable.
You see, in my head, we're trained to be trainable, right? And the right answer in my head is yes, right? Because that shows that the person is willing to improve and, feels empathetically for the family and whatnot.
Right. That's not the jury heard that again, the case went to trial. I testified the best I could for him. I laid out the story and I said 100 times outcome is irrelevant because I knew he said that on deposition, obviously. But that was the closing argument of the plaintiff. The defense attorney, when he called to tell me he lost the case, I asked him why it was that sentence. They said because the jury foreman said the surgeon said he would make a change and that was reasonable and we found for the plaintiff.
Yeah. And that's why I think this is something doctors need to hear, because you need to switch your mindset when you're going into a courtroom because you're defending yourself and your processes.
Did you have a crystal ball to know the outcome? Of course not. Did you meet the standard of care at the time when you're taking care of the patient? Yes. And it's funny, but I use this point specifically at M&M conference. We have a weekly morbidity mortality conference for the surgery residents. As you know, they present all the cases. We go over it. And I ask them that every time when they have a complication. No, and they all answer it the way they should answer it. And I explain because that's how we're trained. I get that. I would have answered it the same way. Of course, we want to improve. That's the point of M&M. Can we learn from our mistakes? But M&M or in hospital is a protected environment that we do learn from our mistakes. The court of law is not a protected environment. and you don't have a crystal ball to know the outcome.
So what's one thing that you wish physicians understood or knew more about medical malpractice litigation? I know we've already covered some.
Yeah, there's really two facets to that. I think number one, if you're asking me as the physician getting sued, I think the most important thing is you're not alone. There is help out there through podcasts like this, through the connection I'm going to make with Dr. Pensa, to others of us that are in this field that are happy to talk to you. They don't charge you anything, just to help you understand that it's a battle. And if the attorneys can win on a technicality, they're going to do that. They don't care. It's all about winning. The truth doesn't matter. It's a game to them, obviously. And I think the other thing is, if you're the kind of physician that wants to get into medical legal work, it is not easy. It is not easy. It takes a lot of time, and you have to be dedicated. And the residents that listen to me talk about it, I tell them, if you want to get into this field, picture this in your mind. You have to sit across the table from a board certified physician like you, that's educated like you, that's trained as long as you, that's taking care of as many patients as you. You need to look at them in the eye and tell them they fell below the standard of care and they harmed a patient. Can you do that? If you can't do that, don't get into this field. Before COVID, all the depositions were in person, and they're starting to do more in person now, but we do a lot of Zoom because of COVID and all that other stuff. But I have been in depositions sitting arm's length away from the surgeon that I said killed a patient. Can you do that? A lot of doctors can't do that. You can't do all defense work. I mean, yes, most of us might want to, but you're not credible. You have to be able to opine against someone your equal and tell them they fell below the standard of care. If you can't do that, you can't get into this work. It is challenging. Can be intimidating. I was very intimidated 30 years ago. Now I'm not, as you can tell. Now I'm not intimidated. Standard of care is standard of care. So I'm okay. I know I do a service for those physicians that I prevent lawsuits, but I can tell you story after story after story of care that is abysmal, that I know these doctors didn't learn this in training. I mean, it's amazing to me, the things that happen and the things that some doctors say under oath that is okay, which is terrible.
So what do you say about supervising? The medical legal landscape for physicians has been getting somewhat more dangerous, I feel, as we are having to supervise or have other professionals work under our license. Is there any advice, or would you mind sharing an experience about cases like that?
Yeah, so there recently was a trial case that I was involved in a month ago in a different state than I reside in, where that's exactly what happened. And I'll make a long story short. The case is already over, but it was a young 31-year-old with a diagnosis of colon cancer, biopsy proven, that had successful surgery, had chemotherapy after surgery, and was being followed appropriately based on the guidelines of following up a patient after colon cancer surgery. His 1-year CAT scan was normal. His 2-year CAT scan was normal. His 3-year CAT scan is where the problem started. There was a new identifiable lesion on CAT scan, stated by the radiologist, worrisome for recurrence, suggested a PET scan. Patient was asymptomatic, no symptoms at all. He was being managed by a PA in the office of a medical oncologist, not even being followed by the surgeon. That's how they did it, which is fine. The rules at that time was that this PA is under the auspice of the medical oncologist who never saw the patient. The PET scan came back normal. The PA told the patient, don't worry about it. I'll see you back in a year. And that was just scar tissue. Didn't say scar tissue anywhere on the CAT scan, but that was documented by the PA. The medical oncologist never saw the patient, but he signed off on the report. Documented. 18 months later, metastatic colorectal cancer, died 2 years later, had unresectable cancer. I opined against the practitioners because a negative PET scan doesn't rule out a recurrence. The patient needed to see the surgeon. It was an early recurrence, more likely than not resectable, and would have had a longer lifespan. And went to trial. It was a multi-million-dollar settlement, against the providers, but therein lies the supervisory role, is that medical oncologist never saw the patient, signed off on the report, now has the responsibility. Now, having said that, in that particular state, those advanced practice providers, PAs, nurse practitioners, are now licensed independent practitioners, which they can make independent decisions, but they take the liability. So if you're in a supervisory role, you have to be extremely careful of the amount of autonomy you give, because you are liable.
Right.
And I give kudos to the medical oncology who actually got sued, but was very honest in his deposition. But you have to be. I mean, the question was simple. Doctor, had you have known, because he signed off on the report, but he said he doesn't remember. And that's reasonable. It was 2 years before. Had you have known that there was an abnormal CAT scan with a normal PET scan, would you have sent the patient to see the surgeon? And he said yes.
Now, what if he hadn't signed that chart? What if he was just the doctor that employed the practitioner?
Well, great question. So back when this case started in 2017, the PA was not a licensed independent practitioner. He had full responsibility. Had that happened in 2025, he would not have been sued. Why? Because they changed the rules in that particular state where the PA was a licensed independent practitioner. He had zero liability, but it was the timing. So in my state, I'm in Virginia. I have a supervisory role of 3 or 4 nurse practitioners. They're licensed independent practitioners. If they make a decision on their own, I am not liable for that. Now, they know that. They will run everything by me. Once they say, hey, I got this CAT scan report. What do you think we should do? I think we should do X, Y, and Z. I say, I agree with you. They document that. Now I have the liability, right? Mm-hmm. So we work as a team, but it depends on the jurisdiction. It depends on the rules of the state of who is responsible for that provider.
That makes sense. Now, are there any other tidbits that you have about how doctors can protect themselves from malpractice cases?
That's a great question, and I tell this almost on a daily basis to the residents. The question is, who's the driver of lawsuits? Do you think the driver of the lawsuit is the patient? The answer is a resounding no. Most patients like their doctor. You've bonded with them, especially in surgery. They come to me after a diagnosis. We talk about surgery, the options. I take them through a surgery, complex or not. I see them while they're in the hospital. I follow them. They don't want to sue their doctor in general. Okay. Mm-hmm. The driver of the lawsuit are the family members when there's a bad outcome, maybe a death or a life-altering complication. A year later, because there's a 2-year statute of limitations in most jurisdictions in this country, it's the family members. So my advice is, when the family member wants to talk to you, don't blow them off like I used to do as a resident. There's a reason you don't blow them off. Make the time. Get them involved. Most men, when they're talking about a big cancer surgery, bring their wives, because men are terrible consumers of healthcare. They don't remember anything. When I'm sick, they don't. And I resemble that, and that's fine. But when a man comes to their third post-op visit by themselves for the first time without their wife, and I see that as I walk into the room. Oh, Mr. Jones, you must be feeling okay because your wife's not here. And they laugh at me. They go, how did you know? I said, if you are having a problem, your wife is right by your side because you're a man and you have no idea what you're doing. And I get that. And that's fine. But, women are much more in tune with healthcare, and that we know that. So if you're dealing with a man, and I'm at the VA Medical Center, so most of our patients are men, but we do have a high percentage of female, get the families involved and documentation. And that you hear that, from day one of medical school. You've got to document not just what you're doing, but what you're thinking. Put the differential in. The last defense case that I just reviewed for a big defense firm, the documentation was fantastic. I mean, he basically, vomited on the page of the differential of the post-op fever, and he went through the 5 W's. I did a chest x-ray. It's not the lungs. I did a urinalysis. The wound looks good. Yes, I'm concerned about a leak, but he's on day 3. A free air on the CAT scan wouldn't he basically presented it like a conference. And that is great. And I told the defense attorney, this is how we're going to win the case. Because they went through the differential, because the other side is going to bring up the things that you don't think about. Well, did you think of this? Well, yes, I thought about it. But you didn't document it, doctor, did you? And they use the no documentation, it didn't happen all the time. And I know over the years, you can rely on, well, this is the way I always do it. This is the way I always document. I know it's not there, but that's how I always do it. Juries don't like that. You didn't document it. It didn't happen. So getting the families involved for sure, if and when they're there, if and when they ask, don't blow them off. And the key to your defense is your documentation.
Fantastic. Great tips. So now you're working at the VA, and the VA is kind of known as a lower liability place. Would you agree? How does that compare to the public world?
Yeah, so it is, but it isn't. So the way it works in the VA system, that if a patient brings a lawsuit, they sue the federal government. They don't sue me individually. So there's different levels of panels that go through. I'm actually on a national peer review committee that we review all cases that are settled less than $50,000. So I'm on a national committee. So what happens is the suit gets filed. It goes to a panel within the VA of attorneys and retired doctors. They decide if they want to pay the patient or not. So they don't decide breach in the standard of care. They decide should we pay this patient a certain amount of money for the harm or the aggravation or for what happened. They always err on the side of making a payment. Why? Because they're veterans. And the overall arching mission is we take care of those who served us. So in the VA world, there are many more payments made out to the veterans for any issue, even a complaint. And all of us in the committee, when we review these charts, we say in the private sector, this is defensible. And the attorneys on the call have to reiterate, we don't look at it like that. We want to make the veterans happy. And that's fine. If and when there's a payment that goes out, that's kind of like double jeopardy. Those veterans then can't go in the private sector and hire an outside attorney and sue me directly. So the VA looks at it like we make the veterans happy. We then protect the doctors because then they can't get sued separately. And that's fine. Now, does it protect the doctors from being reported to the National Data Bank? The answer to that is no. So the committee I'm on is we review all settlements made under $50,000, and we review it. It's a multidisciplinary team, surgeons, hospitalists, medical doctors, nurses, attorneys that work for the VA. And we look at it, was it a breach in the standard of care? Should this be reported to the National Practitioner Data Bank? That's what our job is. So we look at the case. We know the payment's already been made. We're not arguing that. But did the practitioner fall below the standard of care? Should they be reported to the National Data Bank? So as a VA physician, you don't get named in the suit. Payment has nothing to do with it, but you can be reported if the committee feels you fell below the standard of care. And again, I would say 90% of the cases that I've reviewed in the past year from this committee, the provider is not reported to the National Practitioner Data Bank. It's common things that happen. Anesthesia accidentally knocks out a tooth, and the claim is they just want to get money to get their tooth fixed. That's a known complication. We review a lot of colon perforations from colonoscopy that gets recognized and fixed timely, known complications. So 90% of the time that we review, not reported, but there is payment to make the veteran happy, which I think is a good mission of why we're there anyway.
And the payment that's made, is that something we have to report if we credential at any other place?
No. If it's not reported to the National Practitioner Data Bank, there's no reporting that's necessary. If we review the case and we say, yes, the practitioner, there was stool leaking out of the abdomen for 3 days. The patient was hypotensive in the intensive care unit. They were day 7 of a colectomy. You should have operated sooner. That gets reported to the National Practitioner Data Bank as the individual provider, and then they'll have to make it. Then if they get recredentialed, then that will come up. But again, they weren't sued directly, but it is reported that they were named in a lawsuit, and the amount is confidential.
Okay. So since we are a financial podcast and you've probably dealt with some of the finances of the doctors that you've helped in litigation, is there anything doctors can do financially to protect themselves if they get sued?
Yeah, and that's a great question. The residents ask me that all the time. First of all, we all have, you never have to worry about losing your finances, losing your 401k, losing your house, getting things repossessed. We have malpractice insurance. Malpractice insurance covers that most, if not all of the time. Now, if you're named in a lawsuit and you don't want to settle, see, most medical malpractice insurance, we don't have a lot of say of settlement. That's up to the insurance company. It's in the fine print of what you signed that none of us ever read. But if the carrier that covers your malpractice insurance wants to settle and you say, no, I did nothing wrong, and you go to trial and you lose and the sum is above what they're covering you for, yeah, you're writing a check for that. None of us would ever do that. So because most cases settle anyway, number one, because most of the decision is not the doctor's, but it's your malpractice insurance carrier, usually the settlement is at or lower than what you're covered for. There's no money coming out of your pocket. So you almost never have to worry about that issue unless you want to fight it on your own. I don't see any doctor ever doing that. The other thing that I did, and this is because my dad told me this, is, even way back when, before the medical legal issue came up, is I put everything in my wife's name anyway. Now, a lot of my colleagues say that's a bad idea for obvious reasons, but I don't care, right? So I don't care. I put everything in my wife's name. I don't own anything except for the clothes that you're looking at. So cars, houses, it's all in my wife's name. So I never have to worry about that. I know a lot of people listening to this podcast because of other issues would never do that, but I did that. So that's my suggestion, but you have to talk to your spouse about that for sure, because that's a whole can of worms that I'm not breaking up with that today.
Well, thank you for sharing that. We've talked about a lot of heavy things during this half hour, so let me end with a lighthearted segment. We're going to do a quick fire segment. Just answer with the first thing that comes to mind. We won't hold you to it. You ready?
Ready.
All right. Early morning rounds or late night cases?
Early morning rounds.
Morning person. Got it. Malpractice trial or M&M conference?
Oh, malpractice trial. It's like I'm on a stage. It's fantastic. Yeah.
Really? I would not have chosen that. OR playlist, silence or music?
Oh, absolutely music, country music. And when the nurses complain they don't like country, I emphasize to them the only reason I became a surgeon is so I can choose the music, so it's country.
I love it. Who's your favorite artist?
Oh, Rascal Flatts, Lone Star, Hootie and the Blowfish. Yeah, I'm old school, kind of, not really.
Best financial decision you've made?
Oh, boy, many of them. I would say the best thing is having multiple streams of income. Number one, diversification, and opening up a 529 plan in 2001 for my kids when that first came out. The earnings you make on that 529 plan is not taxable. That is the best thing ever. if you have kids, get into a 529 plan for sure.
Love it. And your favorite post-call indulgence?
Oh, Baskin-Robbins ice cream.
Well, Dr. Cohen, thank you so much for coming on our podcast today. Listeners, thank you so much for listening to the Finding Financial Freedom podcast. I hope you enjoyed Dr. Cohen's insights, and I hope you feel like you learned a little bit and know a little bit more I hope you feel like you learned a little bit about this I hope you feel like you learned a little bit more about this extremely uncomfortable topic and feel a little bit more prepared should the worst happen. If you enjoyed this episode, please make sure to give us a follow and leave us a review on any of your favorite podcasting platforms. Share this podcast with someone you know who might be able to enjoy it and learn from it as well. And thank you as always for being here. We really appreciate all of your support. Until next time, stay frugal, y'all.
The content shared on this podcast should not be taken as individualized financial advice. We are here to share our knowledge and experiences, but it is crucial to consult with professionals such as accountants, financial advisors, or attorneys who can provide personalized guidance based on your specific needs.